This video was created as a project for the Human Inheritance course NASE 319 at Bentley University in the fall of 2017. Achondroplasia is a genetic disorder that causes dwarfism. There are more than 200 conditions that can result in dwarfism. Dwarfism is defined by the advocacy group Little People of America as an adult height of 4 feet 10 inches or under as a result of a medical or genetic condition. The average height of an adult with dwarfism is 4 feet. The two main categories are disproportionate and proportionate dwarfism. Proportionate dwarfs have shortened proportionate body parts, whereas disproportionate dwarfs can have an average-sized torso with shorter extremities, such as the arms and legs, or a shortened torso with longer limbs. Achondroplasia is the most common form of dwarfism, occurring in 1 out of 26,000 to 40,000 babies. This disorder is apparent at birth, usually manifesting in long trunks with shortened upper body parts of the leg and the arm. Other physical characteristics of the disorder include an unusually large head, a prominent forehead, and a flat nasal bridge. The FGFR3 gene is the only gene known to cause achondroplasia, and a gene mutation on the FGFR3 gene will result in achondroplasia. The FGFR3 gene makes the protein fibroblast growth factor receptor 3, which is involved in the converting cartilage into bone. When FGFR3 protein binds to fibroblast growth factors, it slows down growth for certain bones. A mutation of the 380th amino acid, glycine, usually is the mutation causing achondroplasia. Glycine and the FGFR3 protein swap, causing the FGFR3 receptor to constantly be active. The mutation causes the receptor to behave as if it's binding a FGF even though it is not. This sends a signal that in turn inhibits bone growth. This FGFR3 that is always active causes chondrocytes at the growth plate to proliferate slowly and become disorganized. This mostly affects endochondral bone formation, the process causing bones to elongate. The process is when bones form on previously laid down cartilage matrix. This elongation process is thwarted when the mutation is present, affecting longer bones like the humerus and phalanges. Bones that result from the intramembranous bone formation are less affected, since this is where bones grow without an existing cartilage matrix. These bones are flat, such as the skulls and the ribs. This process is a positional growth or widening of the bones, which also happens normally for people with this disorder. This is why people with achondroplasia have disproportionate stature due to their short yet wide bones. If two parents have achondroplasia and their child has a 25% chance of inheriting two defective genes, which would result in the infant being born with homozygous achondroplasia, which is fatal. This condition usually results in stillborn births or the infant dying within a few months of being born. This disorder is fatal due to respiratory complications. These complications occur because of thoracic constriction. Homozygous achondroplasia is an example of a disorder classified as a lethal allele. Lethal alleles are alleles causing an organism to die with the mutant's genes is an essential gene. Geneticists used to believe that mutations only altered the appearance of a living organism. Not until later on did geneticists discover that a mutant allele could cause death. Lethal alleles can be both dominant and recessive. In the case of homozygous achondroplasia, a dominant lethal allele causes the disorder. If a dominant lethal allele causes the mutation, both the homozygous and heterozygote of the allele will show the lethal phenotype. Studying this form of the disorder is extremely difficult since the infants die at such a young age. Achondroplasia can be diagnosed after your child is born. A doctor can diagnose a child by looking at its features or taking x-rays to measure the length of an infant's bones. Genetic testing of a child's blood will determine if they have the defective FGFR3 gene. There currently is no cure or treatment for achondroplasia. Ear infections may be more prevalent, so doctors provide antibiotics for their patients. Severe cases may result in spinal stenosis, in which case surgery may be the most viable option to alleviate pain, or nerve block shots. Some doctors have used growth hormones in an attempt to increase growth rates in children's bones. The long-term effects of these hormones are still unknown. There are limb-lengthening surgeries, but most treatment methods are not highly practiced. The biotech company BioMarin announced in 2015 positive phase 2 proof of concept results for its drug vosoritide. The website reads, vosoritide binds to a specific receptor which initiated intracellular signals that inhibit the overactive FGFR3 pathway. The investigational treatment is being studied in children with achondroplasia under the age of 18 because their bones are still amendable and growth. This is a huge step for people who suffer from achondroplasia. Many people can experience serious health problems from the disorder, including foramen magnum compression, sleep apnea, bowed legs, mid-face hypoplasia, and permanent sway of the lower back, spinal stenosis, recurrent ear infections, and obesity. Providing any relief is a huge step for a disorder that a cure has not been able to or heavily pursued as others. Thank you for listening to my presentation on achondroplasia, and I hope that it helped you learn something about the genetic disorder.